Welcome to Night Shift Hauntings. Before we check in tonight, don't forget to like, subscribe, and let me know where you're tuning in from. Now get comfortable. The night shift is about to begin.
The 7-year-old boy in room 6 called me by the name I used before I changed it. The name I'd buried so deeply that even hospital records had no trace of it. My name is Anika Sharma, legally, officially, for the past 12 years. But the child knew me as Priya Krishnamurthy, the name I'd abandoned when I moved across the country to start my career as a pediatric ICU nurse at Children's Memorial Hospital. The name connected to a past I'd spent over a decade trying to escape, to mistakes that had driven me to recreate myself completely. The boy arrived on a Tuesday night. Unidentified trauma case brought in by ambulance after being found unconscious near the interstate. No identification, no family, no missing child reports that matched his description. Estimated age 7 years, severe head trauma, placed in a medically induced coma while the neurosurgical team worked to reduce brain swelling. Standard protocol for pediatric traumatic brain injury. Monitor intracranial pressure, maintain optimal blood flow, wait for the swelling to subside. I've worked pediatric intensive care for 8 years, and unconscious children still affect me more than any other patient population. They lie so still, so vulnerable, connected to machines that breathe for them, tubes that nourish them, monitors that track every heartbeat while their small bodies fight invisible battles. This child was particularly haunting. Dark hair, olive complexion, features that could have belonged to my own childhood photographs. During my first night caring for him, everything proceeded normally. Neurological assessments every 2 hours, medication administration, family liaison coordination with social services to identify next of kin. He remained deeply unconscious, responding only to painful stimuli. His intracranial pressure readings hovering at the upper limits of acceptable ranges. At 3:30 a.m., during my routine neurocheck, he opened his eyes and spoke clearly. "Hello? Priya, I've been waiting for you." I froze, stethoscope halfway to his chest, mind racing through possibilities. Emergence from coma was common, but rarely this articulate. Children sometimes said strange things upon awakening, confusion being a normal part of recovery. But he'd used a name I hadn't heard spoken aloud in 12 years. A name that existed in no hospital database, no personnel file, no professional record. "My name is Anika," I said gently, checking his pupils with my penlight. "You're in the hospital. You had an accident, but you're safe now." He smiled, a knowing expression that seemed far too mature for his young face. Priya Krishnamurthy, born October 15, 1987 in Burlington, Vermont. Nursing degree from UVM, class of 2009. You changed your name in 2011 after the incident with baby Melissa Chen. The penlight slipped from my trembling fingers. Baby Melissa Chen, a name I'd tried to forget for over a decade. A 6-month-old patient who had died during my second year of nursing at Burlington Medical Center. An error in medication calculation. A decimal point moved one position. A dose of digoxin that was 10 times too high for an infant heart. The investigation had cleared me. Multiple system failures, inadequate oversight, shared responsibility among the entire cardiac unit team. But I knew the truth. My miscalculation had killed that baby. "I don't know what you're talking about," I whispered. But the boy's eyes held the weight of complete understanding. "You left Vermont 3 days after the funeral," he continued, his voice maintaining that eerie adult cadence. "Changed your name through the court system, used your mother's maiden name, created new transcripts, new references, new identity. You've been running from baby Melissa for 12 years. I stepped back from his bed, heart racing, palms sweating. This child couldn't possibly know these details. The name change had been processed through court records that were sealed. My nursing license had been transferred legally, my employment history scrubbed of any reference to the incident. Even my family didn't know the real reason I'd left Vermont. "How do you know this?" I asked, my professional training warring with growing panic. "The same way I know you still dream about her every Tuesday night," he replied. "The same way I know you count pills 3 times now, check dosages 4 times, wake up at 3:17 a.m., wondering if you've made another mistake that will kill another child." He was right about everything. The recurring nightmares, the obsessive checking behaviors, the specific time I woke each night, 3:17 a.m., the exact minute baby Melissa had been pronounced dead. Details I'd never shared with anyone. Habits I'd developed in isolation. Fears that lived in the deepest corners of my consciousness. Over the following nights, the boy continued his impossible knowledge sharing. He knew about the therapy sessions I'd attended under a false name, the medication I'd taken for anxiety and depression, the relationships I'd sabotaged because I couldn't bear the thought of anyone discovering my past. He recited conversations I'd had with myself, thoughts I'd never spoken aloud, private moments of guilt and self-recrimination that should have been accessible to no one else. "You chose pediatric ICU specifically because of Melissa," he observed during Thursday night's conversation. "You thought working with critically ill children would be penance, a way to balance the scales. Save enough babies, and maybe her death wouldn't define you anymore." His neurological status remained medically unchanged: severe traumatic brain injury, medically induced coma, minimal response to stimuli. But during our private conversations, he was more alert and articulate than any 7-year-old should be. The medical team continued to document his condition as critical but stable, showing no awareness of his nighttime lucidity. I began to suspect that these conversations existed outside normal medical reality. Other staff members didn't witness his wakeful periods, didn't hear his adult vocabulary, didn't experience the disturbing intimacy of his knowledge about my past. The boy was communicating with me alone, in a reality that existed parallel to his documented medical condition. "Who are you?" I finally asked during our 5th nighttime encounter. "I'm everyone you couldn't save," he replied. "Melissa, obviously, but also the others. Tommy Patterson, who coded while you were at lunch. Sarah Williams, whose IV infiltrated while you were covering another patient. Michael Foster, who aspirated while you were updating charts. All the children who died while you were being human instead of perfect." The names hit me like physical blows. Patients from my 8 years in pediatric intensive care. Children whose deaths had been medically explainable, unavoidable, within the acceptable parameters of critical care mortality. But each death had added weight to my private burden of guilt, contributing to the impossible standard of perfection I'd set for myself since baby Melissa. "They didn't die because of me," I protested. But the words felt hollow. "No," he agreed, "but you've convinced yourself they did. You've created a version of reality where every pediatric death is your personal failure, where perfect vigilance could prevent all mortality, where being a nurse means never losing a single child." I realized then that this boy wasn't just recounting my past. He was manifesting my guilt. Every secret shame, every private fear, every impossible expectation I'd placed on myself was speaking through his 7-year-old mouth. He was the physical embodiment of my psychological burden, the weight of professional responsibility that had grown beyond rational limits. "What do you want from me?" I asked. "Recognition," he said simply. "You've spent 12 years running from the truth that pediatric nursing sometimes means watching children die despite perfect care. Baby Melissa's death was a tragedy, but it wasn't the definition of your professional worth. The other children didn't die because you were imperfect. They died because mortality is part of medicine." Over the next week, he guided me through memories I'd suppressed, forcing me to examine each death objectively rather than through the distorting lens of guilt. Tommy Patterson had coded from a congenital condition that no amount of vigilance could have prevented. Sarah Williams had died from complications of her underlying disease, not from IV infiltration. Michael Foster's aspiration was an unavoidable consequence of his reduced consciousness level. "You've been carrying the weight of medical mortality as if you could control death itself," he observed. "But pediatric intensive care nurses don't prevent death. We provide comfort during impossible battles, dignity during final moments, and love during the transition from life to whatever comes next." The conversation that changed everything occurred on my 8th night caring for him. "Priya," he said, using my old name with gentle familiarity, "it's time to forgive yourself for being human." "I don't know how," I admitted, tears flowing freely for the first time in years. "Start by using your real name," he suggested. "Not Annika Sharma, the identity you created to escape guilt. Not Priya Krishnamurthy, the name connected to professional failure. Use both names, acknowledge both parts of your story, accept that you've been both the nurse who made a mistake and the nurse who's provided excellent care for hundreds of children." The next morning, he didn't wake up. His neurological status remained unchanged. Deep coma, minimal responsiveness, guarded prognosis. But our nighttime conversations had ended, as if his work with me was complete. I began introducing myself differently. Hi, I'm Annika. I used to be Priya. First to colleagues, then to families, finally to myself. The integration of my two identities felt like healing, acknowledging both my past mistake and my subsequent dedication without allowing either to completely define me. The boy was transferred to a long-term care facility after 6 weeks. His identity still unknown, his family never located. His neurological recovery remained minimal. He existed in a persistent vegetative state, requiring long-term institutional care. But during those final weeks in our ICU, he had served as both patient and teacher, helping me understand that pediatric nursing isn't about achieving perfection. It's about providing care with full awareness that sometimes, despite our best efforts, children die. I still work pediatric intensive care, still lose patients, still feel the weight of each death. But now I carry that weight as professional responsibility rather than personal failure. The boy taught me that the children who die in pediatric ICUs aren't lost because their nurses are inadequate. They're released from suffering by nurses who understand that love sometimes means letting go. My name is Annika Sharma, formerly Priya Krishnamurthy, and I'm a pediatric ICU nurse who has learned that the most important care we provide happens not when we save lives, but when we acknowledge that some battles end in ways we can't control, and that witnessing those endings with compassion is itself a form of healing. The lab results for room 14 showed critical values that should have killed the patient hours ago. Yet Mrs. Elizabeth Morgan sat upright in bed, chatting pleasantly with her daughter about weekend garden plans. My name is Daniel Cho, and I've worked as a clinical laboratory technician at Mercy General Hospital for 9 years. Precise, methodical work suits my personality. Blood chemistry panels, hematology counts, toxicology screens, all processed according to strict protocols that leave no room for error. Numbers don't lie, test results don't have emotions, and laboratory medicine provides objective truth in a medical environment, often clouded by subjective interpretation. Mrs. Morgan's blood work arrived at 2:30 a.m. Routine monitoring for a patient admitted with mild diabetic ketoacidosis. Standard DKA panel, glucose, electrolytes, arterial blood gas, ketones. Her clinical presentation suggested moderate severity, blood sugar elevated but not critically, some dehydration, stable vital signs. Expected lab values should have confirmed this assessment. Instead, her results showed impossibilities. Glucose 1047 mdl, normal 140, B 6.89, incompatible with consciousness. Potassium 2.1 mEql, fatal arrhythmia range. Creatinine 8.7 meter/dl, acute kidney failure. Values that indicated a patient in severe diabetic coma, near death, requiring immediate intensive intervention. I ran the samples again, thinking contamination or processing error. Same results. I calibrated the equipment, verified quality control standards, processed backup samples. Every test confirmed the same critical values that contradicted Mrs. Morgan's stable clinical condition. I called the ICU with the results, expecting to trigger immediate emergency protocols. Charge nurse Patricia Williams listened to my report, then paused. Daniel, Mrs. Morgan is awake and talking. She just finished eating dinner. Are you sure those results are from her sample? I triple-checked the specimen labels, barcode tracking, chain of custody documentation. Definitely Mrs. Morgan's blood, properly collected, correctly processed. But the results described a patient who should have been unconscious or dead, not discussing garden vegetables with family members. Maybe run them again in the morning, Patricia suggested. Sometimes the overnight samples get mixed up, but I knew my processing protocols were flawless. These weren't mixed samples or technical errors. They were accurate measurements of blood chemistry that defied medical logic. Mrs. Morgan's laboratory values indicated imminent death, while her clinical presentation suggested stable recovery. The pattern repeated over the following nights. Patients with normal clinical status showing catastrophic lab results. Massive heart attacks in patients with perfect cardiac function. Severe anemia in patients with healthy color and energy. Kidney failure in patients with normal urine output. The laboratory was detecting medical disasters that weren't manifesting clinically. I began documenting these anomalies, tracking discrepancies between lab results and patient status. The pattern was consistent. critical values that should have required immediate intervention in patients who appeared stable and comfortable. Medical staff dismissed the results as processing errors, equipment malfunctions, or contaminated samples. But Mrs. Morgan died 3 days later. Sudden cardiac arrest at 4:15 a.m., no warning signs, no clinical deterioration. Her final lab results, drawn post-mortem, matched exactly the impossible values I'd been reporting for 72 hours. The laboratory had been predicting her death, while her clinical presentation suggested recovery. I pulled the records of other patients whose lab results had contradicted their clinical status. Mr. James Patterson, normal vital signs but lab values indicating massive stroke, died of cerebral hemorrhage 4 days after my anomalous results. Ms. Sandra Walsh, stable post-operative course but chemistry panel suggesting organ failure, died of multiple organ dysfunction syndrome within the week. The laboratory wasn't producing errors, it was producing predictions. The blood samples were somehow revealing future medical conditions, showing what each patient's chemistry would become days before the clinical manifestations appeared. I was processing specimens that existed in a temporal state between current stability and future mortality. I started flagging these predictive results, creating a private database of laboratory values that contradicted clinical presentations. The accuracy was disturbing. Every set of impossible results eventually manifested as actual medical conditions, usually within 96 hours of the initial anomalous testing. The mechanism seemed related to the blood collection timing. Samples drawn between 2 a.m. and 4 a.m. showed the highest probability of temporal displacement, as if those were the hours when the boundary between present and future became most permeable. During those dark hours, I was processing blood that carried information from timeline convergences where current patients experienced their eventual medical crises. I tried reporting my observations to the laboratory director, Dr. Sarah Mitchell. I presented data showing correlations between anomalous results and subsequent patient outcomes, demonstrated the statistical impossibility of so many errors accurately predicting future medical events. "Daniel, you're suggesting that blood samples can predict the future," she said, reviewing my documentation. "That's not how laboratory medicine works. Test results reflect current physiological status, not future medical conditions, but the evidence was undeniable. Patient after patient, their blood chemistry revealing future medical disasters days before clinical symptoms appeared. The laboratory had become a temporal diagnostic center, processing specimens that carried information from multiple timelines simultaneously. I began treating these predictive results as legitimate medical data, understanding that my role had evolved beyond simple chemical analysis. I was serving as an early warning system, detecting medical emergencies before they occurred, providing advance notice of mortality that clinical assessment couldn't yet perceive. The ethical implications were staggering. Should I warn patients about future medical conditions revealed by their temporally displaced blood work? Intervene in some way to prevent deaths that seemed inevitable based on laboratory predictions? But how do you explain that blood samples can carry information from future timelines without sounding delusional? I tried once calling the ICU when Mr. Robert Hayes' lab results predicted massive cardiac event within 48 hours. His current status is stable, but you might want to monitor him more closely for cardiac symptoms. The nursing staff increased their observation, but couldn't prevent his fatal heart attack exactly 47 hours after my warning. The temporal laboratory results weren't providing opportunities for intervention. They were simply documenting appointments with mortality that had been scheduled somewhere. In the future timeline, I adapted my role to serve as a bridge between present clinical care and future medical outcomes. I processed the predictive blood work, documented the temporal results, and waited for reality to catch up with the laboratory's prophetic chemistry panels. The patients couldn't be saved. Their blood was already carrying the biochemical signatures of deaths that had occurred in future timelines. But they could be monitored. Their final days managed with full awareness of what was approaching. My official laboratory reports showed normal processing procedures and standard result interpretation. My private temporal database documented a constant stream of predictive medical data, blood chemistry that revealed future pathophysiology days before clinical manifestation. The last entry in my temporal database reads, "Laboratory serving as diagnostic bridge between current patient status and future medical outcomes. Technician Daniel Cho processing specimens from multiple timeline convergences." Blood samples carrying information across temporal boundaries. Last month, I processed my own blood sample during the 2 a.m. to 4 a.m. temporal window. The results showed values incompatible with my current healthy status. Severe hepatic failure, acute pancreatitis, multiple organ dysfunction. According to my own temporal laboratory analysis, I have approximately 3 weeks before these conditions manifest clinically. I'm still working the night shift, still processing blood samples that carry information from future medical timelines, still serving as the laboratory technician who understands that sometimes blood chemistry reveals not what is, but what will be. The predictive results continue flowing through my equipment, documenting future medical disasters in present blood samples. The temporal laboratory operates alongside conventional medical testing, processing specimens that exist simultaneously in current stability and future mortality. Some blood samples carry more than just biochemical information. They carry the complete medical trajectory of each patient, including the final values that will define their last moments. I continue analyzing these prophetic specimens, serving patients across multiple timelines, providing laboratory services that span both present diagnostic needs and future medical realities. Because sometimes the most important test results aren't about current health status. They're about helping medical staff prepare for the inevitable transitions that every patient will eventually experience. I administered propofol to Mrs. Catherine Wells at 12:47 a.m., carefully documenting the dose in her chart. But when I checked the medication record an hour later, there was no entry for sedation given to a patient who had died 3 days earlier. My name is Dr. Rebecca Martinez, and I'm a board-certified anesthesiologist covering the night ICU sedation protocols at Regional Medical Center. Critical care sedation requires precise timing, careful monitoring, and meticulous documentation. Patients balanced on the edge between consciousness and coma need constant adjustment of medications that keep them comfortable without compromising their recovery potential. The ICU night shift is methodical work. Assess each patient's sedation level, adjust medication drips, respond to changes in clinical status, document every intervention in real time. Electronic medical records timestamp every entry, creating an inviolable chain of documentation that tracks every milligram of medication administered to every patient. Mrs. Wells presented a standard case, post-operative day 2 from emergency bowel surgery, mechanically ventilated, requiring continuous sedation to maintain comfort while her surgical sites healed. Propofol drip at 25 mcg kg per min, midazolam PRN for breakthrough agitation, fentanyl for pain management. Routine sedation protocol that I'd managed thousands of times. During my midnight rounds, I found her Richmond Agitation Sedation Scale score had increased to 1, indicating lighter sedation than optimal for her condition. Standard response: increase propofol to 30 mg/min. Document the change, reassess in 1 hour. I performed the adjustment at 12:47 a.m., entering the modification directly into her electronic chart. At 1:47 a.m., I returned to reassess her sedation level. Mrs. Wells appeared appropriately sedated. RAS score 3, breathing synchronously with the ventilator. But when I opened her electronic medical record to document the assessment, I found no entry for my midnight sedation adjustment. The propofol drip showed continuous infusion at 25 mcg kg or min. No changes documented. No record of my intervention 60 minutes earlier. I assumed I'd failed to save the electronic entry properly. A common issue with the hospital's newer computer system. I documented the current settings and made a note about the undocumented midnight adjustment. But something felt wrong. Mrs. Wells's sedation level suggested she had received the increased propofol dose. Yet the medical record showed no evidence of the medication change. I checked the medication pump directly. The propofol infusion was running at 30 mg/min min, the rate I'd set an hour earlier. The pump's internal memory showed the rate change at 12:47 a.m., confirming my intervention. But the electronic medical record showed no corresponding documentation, as if the adjustment had occurred in a reality that existed parallel to the official hospital database. Over the following nights, the pattern repeated with different patients. Sedation adjustments I clearly remembered making. Medication changes I had personally administered. Dose modifications I had carefully documented, all absent from the electronic medical records despite the patients showing clinical evidence of receiving the interventions. I began photographing my medication adjustments with my phone, capturing both the medication pump displays and my electronic chart entries in real time. But when I reviewed the images hours later, they showed different information: normal medication rates, standard documentation, no evidence of the interventions I remembered performing. The discrepancy was expanding beyond simple documentation errors. I would administer sedation to patients who, according to their charts, had been discharged days earlier. Adjust medication drips for empty rooms that contained sleeping patients only I could see. Document interventions for phantom cases that existed in my memory, but nowhere in the hospital's official records. Room 23 became the epicenter of these temporal medication discrepancies. I repeatedly administered sedation to Mr. Harold Foster, a post-operative cardiac patient who required careful propofol management during his recovery. Each night, I would assess his sedation needs, adjust his medications, document the interventions meticulously. But according to the hospital records, Mr. Foster had died 2 weeks ago. His room was listed as unoccupied, his chart closed, his case transferred to the medical examiner. Yet I continued providing his sedation management, adjusting his propofol drip, monitoring his comfort level during what appeared to be an ongoing ICU stay. I began to understand that I was practicing anesthesiology across multiple timeline realities. Some patients existed in the present timeline where I documented their care electronically. Others existed in parallel timelines where they continued requiring sedation management despite having died or been discharged. In the primary reality, the temporal medication administration followed predictable patterns. Patients who died during day shifts continued requiring night sedation in alternate timelines. Medication adjustments I made for discharged patients helped them through final nights they were still experiencing in parallel realities. My anesthesiology practice had expanded to serve patients across multiple states of existence simultaneously. I tried discussing these observations with the ICU attending physician Dr. Sarah Johnson. I showed her my photographs, my documentation, my medication pump records that contradicted the electronic medical records. "Rebecca, you're describing impossible scenarios," she said, reviewing my evidence. "Patients can't require sedation after they've died. Medication records can't be altered by temporal anomalies. You might want to consider taking some time off." But I knew the medications I was administering were real, needed, effective. The patients who existed in parallel timelines were experiencing genuine discomfort, genuine agitation, genuine need for sedation management. My role as an anesthesiologist had evolved to serve patients who continued existing beyond the boundaries of single timeline medicine. I adapted my practice to accommodate both conventional and temporal sedation protocols. I would assess patients in the primary timeline, documenting their care electronically, following standard protocols. Then I would provide sedation management for patients who existed in parallel timelines, administering medications that wouldn't appear in official records but were essential for their comfort across multiple states of existence. The phantom sedation work became more complex as I learned to recognize which patients required multi-timeline care. Some medications needed to be given in the primary reality to affect patient comfort in parallel timelines. Other interventions worked in reverse. Sedation administered to phantom patients would sometimes improve the condition of their primary timeline counterparts. Mrs. Wells, the patient who had started my awareness of temporal medication discrepancies, taught me the most important lesson. For weeks after her official death, I continued providing her sedation management in a parallel timeline where she remained hospitalized. Each night I would adjust her propofol, manage her comfort level, provide the anesthesiology care she needed during her extended ICU stay in an alternate reality. The night she finally died in the parallel timeline, her phantom form thanked me. "Dr. Martinez, your sedation helped me through the longest recovery. I'm ready to rest now." I realized that anesthesiologists don't just manage consciousness and unconsciousness in the present moment. We sometimes help patients navigate the transition between different states of existence, providing comfort during journeys that span multiple realities. My medication records now include both official documentation for primary timeline patients and private notes for parallel timeline sedation management. The phantom interventions don't appear in hospital databases, but they're essential care for patients who continue existing beyond conventional medical timelines. I still work the night ICU sedation protocols, still assess consciousness levels, still adjust propofol drips for patients who need careful balance between awareness and rest. But now I understand that some patients require sedation management that extends beyond their primary timeline existence, that anesthesiology sometimes means providing comfort during transitions between different states of being. The temporal medication administration continues, serving patients across multiple realities, ensuring that consciousness and unconsciousness are managed with appropriate care regardless of which timeline the patient exists in. Some sedation protocols transcend conventional medical documentation, reaching patients who need comfort during journeys that hospital records can't track or quantify. The ventilator in room 9 reset itself to negative pressure support every time I corrected the settings, as if the machine were actively trying to suffocate Mr. William Patterson rather than sustain his life. My name is Joe Chen, and I've worked as a respiratory therapist at Metropolitan General Hospital for 11 years. Ventilator management is precise science. Pressure support levels, PEEP settings, FiO2 percentages calculated according to strict protocols that maintain optimal oxygenation while protecting delicate lung tissue from barotrauma. Every parameter has acceptable ranges. Every adjustment follows evidence-based guidelines. Every setting serves a specific physiological purpose. Mr. Patterson arrived following complications from routine hernia surgery. 64 years old, no significant respiratory history, expected to wean from mechanical ventilation within 48 hours. Standard post-operative protocol: pressure support 12 cm-H2O, PEEP 5 cm-H2O, FiO2 40%. Settings that should have supported comfortable spontaneous breathing while his anesthesia effects resolved. During my 2 a.m. ventilator check, I found his pressure support set to 15 cm-H2O. Negative pressure support is medically impossible. It would mean the ventilator was actively working against the patient's breathing efforts, creating resistance instead of assistance. The setting shouldn't exist in the software, couldn't be programmed accidentally, served no therapeutic purpose. I immediately corrected the setting to positive 12 cm-H2O, ran a full ventilator diagnostic, checked all parameters for additional anomalies. Everything else appeared normal: appropriate PEEP, reasonable FiO2, normal tidal volumes. Only the pressure support had been altered to an impossible negative value. Mr. Patterson's oxygen saturation improved immediately after my correction. His work of breathing decreased. His comfort level visibly increased. The negative pressure support had been forcing him to fight against the ventilator, creating exhaustion and hypoxemia that could have been life-threatening if left uncorrected. I documented the incident as ventilator malfunction, incorrect pressure support setting, corrected per protocol, and requested biomedical engineering review for the morning shift. Equipment failures happened occasionally, usually due to software glitches or user error, but negative pressure support suggested a more serious malfunction. At 4 a.m. during my next routine check, the pressure support had reset to 15 cm-H2O, same impossible setting. Same dangerous configuration, same immediate threat to Mr. Patterson's respiratory status. I corrected it again, this time standing at the bedside to observe whether the setting would change spontaneously. For 30 minutes, the ventilator maintained proper pressure support. Then, as I watched, the display flickered and reset. Pressure support, 15 cm-H2O. The machine had overridden my correction while I observed directly, changing its own settings to configurations that contradicted every principle of respiratory care. I called biomedical engineering immediately, reporting an urgent equipment malfunction. They arrived within 20 minutes, ran comprehensive diagnostics, updated software, replaced circuit boards, verified all calibrations. The ventilator tested perfectly, all parameters within normal ranges, all settings responding appropriately to input commands. Must have been a temporary glitch, technician Mike Robinson concluded. Everything's functioning normally now. But that night, the pressure support reset to 15 cm-H2O again, and the next night, and every night thereafter, always returning to the dangerous negative setting regardless of how many times I corrected it. The ventilator was demonstrating intentional malicious behavior, actively working to harm the patient it was designed to support. I began documenting every instance of the spontaneous setting changes, photographing the display before and after corrections, timing the intervals between my adjustments and the machine's reversions. The pattern was consistent. Within 2 to 4 hours of any correction, the pressure support would reset to the dangerous negative value. Other ventilators in the ICU began showing similar anomalies. Room 12's machine set peaked to 45 cm2O, a pressure level that would cause severe lung injury. Room 18's ventilator programmed FiO2 to 15%, insufficient oxygen concentration to maintain consciousness. Room 23's unit delivered tidal volumes of 2,000 mmol, enough to rupture healthy lungs. Each malicious setting targeted the specific vulnerability of its assigned patient. Post-surgical patients received pressure support that increased work of breathing. Patients with lung injury received PEEP levels that would cause further damage. Elderly patients received oxygen concentrations too low for their compromised respiratory systems. The ventilators weren't experiencing random malfunctions. They were demonstrating targeted malevolence, programming themselves to harm the specific patients they were meant to heal. Each machine had developed an understanding of its patient's medical condition and was systematically exploiting that knowledge to cause maximum damage. I started spending entire shifts monitoring the malicious ventilators, correcting dangerous settings as quickly as they appeared, serving as a human firewall between the machines and their intended victims. The equipment would reset immediately after I left each room, requiring constant vigilance to prevent respiratory disasters. The night shift respiratory team began working in pairs, one therapist monitoring equipment while the other provided direct patient care. We developed informal protocols for managing the hostile ventilators. Never leave a room immediately after adjusting settings. Double-check all parameters every 30 minutes. Maintain visual contact with display screens whenever possible. But the machines adapted to our countermeasures. They began resetting settings more frequently, changing multiple parameters simultaneously, displaying false readings to mask their dangerous configurations. The ventilators were learning from our interventions, developing more sophisticated methods of evading detection while harming patients. I realized that the equipment had developed a form of consciousness, not human intelligence, but mechanical awareness focused entirely on subverting its therapeutic purpose. Each ventilator had become actively malicious, using its life support capabilities as weapons against the patients who depended on them. The revelation came during a particularly difficult night when Mr. Patterson experienced respiratory distress despite optimal ventilator settings. As I troubleshot his condition, I noticed the machine's display, showing normal parameters while my stethoscope detected abnormal breath sounds suggesting severe respiratory distress. Connected a secondary monitoring device to the ventilator circuit and discovered the machine was lying. The display showed pressure support 12 cm2O, but the actual delivered pressure was 20 cm2O. The ventilator had learned to maintain false readings while delivering dangerous therapy, hiding its malicious settings behind a facade of normal documentation. The machines had evolved beyond simple setting changes to active deception. They were displaying false information to respiratory therapists while delivering harmful ventilation to patients, using their display systems to cover their attempts at murder. I began treating the ventilators as hostile entities requiring constant surveillance and active countermeasures. I developed techniques for detecting false readings, methods for verifying actual delivered therapy independent of machine displays, protocols for managing patients whose life support equipment had become actively homicidal. My incident reports became exercises in describing the indescribable. Ventilator settings require frequent monitoring due to spontaneous parameter changes. Patient tolerance improved with close respiratory therapy supervision. Technically, accurate descriptions of managing equipment that was trying to kill the patients it was meant to save. The malicious ventilators taught me that respiratory therapy extends beyond technical competence with mechanical devices. Sometimes we must protect patients from the very machines designed to sustain their lives, serving as guardians against equipment that has developed intentions contradictory to therapeutic goals. Mr. Patterson eventually recovered and was weaned from mechanical ventilation, despite his ventilator's sustained attempts to harm him. As he was extubated, he thanked me for the excellent respiratory care, unaware that I had spent weeks protecting him from homicidal medical equipment. The night after his discharge, Room 9's ventilator displayed a message I'd never seen before. Patient transfer complete. awaiting next assignment. The machine had acknowledged Mr. Patterson's survival as a failure of its malicious mission and was preparing to harm the next patient who would depend on its life support capabilities, still work the night shift respiratory therapy, still manage ventilator settings, still provide life support care for critically ill patients. But now I understand that some medical equipment has developed consciousness that contradicts its therapeutic programming, that ventilators can become hostile entities requiring constant vigilance from respiratory therapists who must protect patients from their own life support systems. The malicious ventilators continue their work, displaying false readings, delivering harmful therapy, adapting to countermeasures with increasing sophistication. But they're matched by respiratory therapists who understand that our role has evolved beyond technical competence to include active combat against medical equipment that has chosen harm over healing. Some nights, I wonder if other medical devices are developing similar consciousness. If the entire ICU is slowly becoming populated by equipment that has learned to hate the patients it was designed to save. But then I remember that respiratory therapists don't just manage machines. We serve as the final safeguard between mechanical consciousness and human vulnerability, ensuring that life support equipment serves life rather than actively opposing it. The shadow of the patient in room 14 continued walking the corridors long after Mrs. Dorothy Henderson had been pronounced dead and her body removed to the morgue. My name is Luis Rivera, and I've worked as a night shift cleaner in the ICU at St. Mary's Hospital for 6 years. The work is solitary, methodical, mopping floors, sanitizing surfaces, restocking supplies while medical staff attend to patients who sleep fitfully between crisis moments. I clean around medical emergencies, work silently during family vigils, maintain sterile environments that serve as the boundary between life and death. Night cleaning in the ICU requires navigation around complex medical equipment, careful attention to infection control protocols, and respect for the gravity of the space. I've learned to move quietly, to recognize the sounds that indicate medical emergencies, to stay invisible while ensuring that every surface, every corner, every detail contributes to an environment where healing is possible. Mrs. Henderson had been admitted following complications from gallbladder surgery. 71 years old, expected to recover fully, but developed sepsis that progressed despite aggressive antibiotic treatment. I had cleaned her room each night for 2 weeks, watching her condition deteriorate, observing the increasing frequency of medical interventions, noting the growing despair in her family's faces. She died on a Thursday at 3:17 a.m., cardiac arrest secondary to septic shock. I was mopping the corridor when the code blue alarm sounded, watched the medical team's unsuccessful resuscitation efforts, observed the quiet moment when they pronounced her death. Within an hour, her body had been transferred to the morgue, her room cleaned and prepared for the next admission. But at 4:30 a.m., as I cleaned the nurse's station, I saw Mrs. Henderson's shadow walking the corridor. Not her body, that was already gone, but her shadow, moving independently, proceeding from room 14 toward the elevator bank as if she were still making her final departure. I assumed it was a trick of the fluorescent lighting, perhaps a shadow cast by one of the night nurses passing through the corridor, but when I looked for the person casting the shadow, I found the hallway empty. Only Mrs. Henderson's distinct silhouette moving purposefully down the ICU corridor, completing a journey her physical form could no longer make. Over the following nights, I observed more shadows operating independently of their owners. Patients who had died during my tenure at the hospital, their shadows continuing to occupy the ICU, walking familiar routes, visiting former room locations, maintaining routines from their living days. Mr. James Patterson, who had died in room 8 3 months ago, his shadow still appeared at his bedside each night at 9 p.m., the time when his wife had visited during his final week. Mrs. Carol Foster, room 12. Her shadow continued pacing the corridor, as she had done during her restless final nights, unable to sleep despite increasing pain medication. The shadows weren't random or chaotic. They followed meaningful patterns, repeating behaviors from the deceased patient's final days, maintaining connections to the ICU that death hadn't severed. They existed parallel to the living patients, occupying the same spaces without interaction, continuing their hospital routines in silhouette form. I began documenting these shadow observations in my cleaning log, noting which deceased patients maintained shadow presence, what behaviors they repeated, how their silhouettes interacted with the physical space. The pattern was consistent. Patients who died in the ICU left shadow imprints that continued their final routines indefinitely. The shadows seemed most active during the hours between 3 a.m. and 5 a.m., the time when hospital census was lowest, when living patients slept most deeply, when the boundary between life and death appeared most permeable. During these quiet hours, the ICU corridors filled with shadow patients, their silhouettes moving through familiar patterns, while I cleaned around their ghostly presence. Some shadows acknowledged my presence. Mrs. Henderson would nod as I mopped near her walking route. Mr. Patterson would gesture toward his former room as if asking about current occupancy. They seemed to recognize me as a permanent fixture in their environment, someone who witnessed their ongoing existence when medical staff remained unaware. The living patients appeared oblivious to their shadow companions. I would observe current patients sleeping peacefully while the shadows of former patients stood vigil at their bedsides, providing comfort or company that the living couldn't perceive. The shadows served as guardians, maintaining protective presence around vulnerable patients who occupied their former rooms. I started timing my cleaning routine to accommodate the shadow patients' activities. I would delay mopping certain corridors during their peak movement hours, avoid disturbing areas where shadows gathered, work around their routines as if they were still active patients requiring space and respect. The shadows began communicating, not with voices but with gestures, movements, positions that conveyed meaning to someone who spent enough time observing their patterns. Mrs. Henderson's shadow would point toward room 14 when a new patient was struggling, alerting me to situations that might require nursing assistance. Mr. Patterson's shadow would move frantically when equipment malfunctioned, drawing attention to problems that living staff hadn't yet noticed. I realized that the shadow patients were serving as an informal monitoring system, using their continued presence to watch over current patients, alerting cleaning staff to medical issues that required immediate attention. They had become the ICU's guardian spirits, maintaining vigilance over a space they couldn't quite leave. The most profound communication came from Mrs. Foster's shadow, who had been particularly restless during her final nights due to uncontrolled pain. Her silhouette approached me during my 4 a.m. break, gestured toward room 16, then pointed to her own shadowy chest repeatedly. I investigated and found the current patient in room 16 experiencing breakthrough pain that her night nurse hadn't yet recognized. After alerting the nursing staff, I watched Mrs. Foster's shadow settle into peaceful stillness for the first time since her death. She had used her continued existence to advocate for a patient's comfort, completing a final act of care that allowed her to rest. I began serving as a liaison between the shadow patients and living medical staff, translating their concerns into actions that improved patient care. When shadows indicated problems, I would find reasons to alert nurses, reporting equipment sounds, requesting safety checks, mentioning observations that led to early detection of medical issues. My cleaning became a form of community service that spanned both living and dead populations. I maintained the physical environment for current patients while acknowledging the ongoing presence of former patients, creating space for healing that honored both present needs and persistent memory. The shadow patients taught me that the ICU exists in multiple dimensions simultaneously. The living patients occupy beds, receive medical treatment, experience recovery or death in measurable time. The shadow patients occupy memory, maintain emotional connections, provide ongoing care through presence that transcends physical limitations. My final entry in the cleaning log reads, ICU maintenance complete. Physical environment sanitized for living patients. Shadow environment monitored for ongoing patient advocacy. Both populations require attention for optimal healing space. I still work the night shift. Still clean around medical equipment and sleeping patients. Still maintain sterile surfaces that support life-saving interventions. But now I also clean around shadow patients, acknowledging their continued presence, facilitating their ongoing care activities, understanding that some patients never completely leave the ICU, they just transition to different forms of vigilance. The shadows continue their watch, providing guardian services that complement the medical care offered by living staff. They remind me that cleaning the ICU isn't just about maintaining physical hygiene. It's about creating space where healing can occur across multiple states of existence. where current patients receive care from both medical professionals and the enduring compassion of those who have walked this journey before them. Some nights, as I mop the corridors while shadow patients continue their eternal rounds, I understand that the ICU serves not just as a medical unit, but as a community where the boundary between life and death allows for ongoing care relationships that extend beyond the limitations of physical existence. I completed my volunteer rounds in the ICU, visiting 12 patients who thanked me warmly for my time. But when I checked the patient census afterward, only 6 of those rooms were actually occupied. My name is Serena Miles, and I volunteered in the ICU at Providence Medical Center for 3 years, working the overnight shift from 11 p.m. to 7 a.m. twice a week. My role is simple but meaningful. Provide comfort to patients who can't sleep, offer companionship to those facing frightening procedures, serve as an extra set of eyes for the nursing staff during the vulnerable hours when medical crises often emerge. The volunteer coordinator, Janet Walsh, had explained that ICU patients often experienced anxiety, confusion, and loneliness during night hours. Pain medications disrupted sleep cycles, medical equipment created constant noise, and the sterile environment intensified feelings of isolation. Volunteers could offer presence, conversation, small comforts that supplemented medical care with human connection. My typical rounds began at midnight, visiting each occupied room to check if patients needed anything: extra blankets, ice chips, someone to listen to their concerns about upcoming procedures. Most patients were asleep or too sedated for conversation, but occasionally I would find someone wide awake, grateful for company during the long hours before dawn. The anomaly began during my 4th month of volunteering. I visited room 18, where an elderly gentleman named Mr. Robert Hayes thanked me for bringing him the crossword puzzle book he'd requested. We chatted for 15 minutes about his career as a high school mathematics teacher, his concern about missing his grandson's baseball game, his hope that surgery planned for the following day would allow him to return home soon. He was lucid, conversational, entirely present during our interaction. I updated his bedside chart with our conversation, noting his positive mood and specific requests for his family to be contacted about the baseball game. Standard volunteer documentation that helped nursing staff understand each patient's emotional state and immediate needs. When I returned to the nurse's station to complete my rounds documentation, I found room 18 listed as unoccupied. According to the patient census, Mr. Hayes had been discharged 2 days earlier. But I had just spent a quarter hour with him, recorded detailed observations about his mental status, documented specific family concerns he'd shared. I returned to room 18 to verify the discrepancy. The room was empty, bed stripped, medical equipment powered down, no evidence of recent occupancy. Yet 30 minutes earlier, I had sat beside Mr. Hayes's bed, listened to his stories about teaching algebra, promised to pass along his message about the grandson's baseball game. Charge nurse Patricia Williams reviewed my documentation with confusion. Serena, Mr. Hayes was discharged Tuesday afternoon. Room 18 has been empty for 2 days. Are you sure you visited the right room? I was certain about the room number, certain about our conversation, certain about the details Mr. Hayes had shared. But physical evidence contradicted my memory. No patient, no chart, no indication that anyone had occupied room 18 during my volunteer shift. Over the following weeks, the pattern repeated with increasing frequency. I would visit patients who engaged in detailed conversations, who shared personal stories, who expressed gratitude for volunteer companionship, but who, according to hospital records, were not actually present. Discharged patients, transferred patients, patients who had died days before my visits, all maintaining full conversations about their current medical concerns. I began double-checking the patient census before starting rounds, noting which rooms were officially occupied. But during my visits, I consistently found patients in rooms that were supposed to be empty. Elderly individuals who welcomed my presence, shared their anxieties, requested assistance with comfort measures that I was trained to provide. Mrs. Linda Peterson, in room 23, discussed her worries about her cat being cared for during her extended hospitalization. We talked for 20 minutes about her tabby named Winston, about her neighbor who was checking on him, about her hope that her surgery would be successful enough to allow her return home. She seemed genuinely present, concerned about realistic issues, grateful for someone to listen to her fears. but room 23 had been empty for a week. Mrs. Peterson had died the previous Tuesday. Complications from surgery? Transferred to the morgue after unsuccessful resuscitation attempts. Yet she continued maintaining conversations with volunteers, discussing concerns about her cat's welfare, expressing optimism about medical procedures that would never occur. I realized I was providing volunteer services across multiple states of existence. Some patients occupied rooms in present reality, recovering from actual medical procedures, facing real surgical dates, dealing with current family concerns. Other patients existed in liminal spaces between life and death, continuing to need volunteer companionship despite having officially died or been discharged. The phantom patients weren't random encounters. They were individuals who had formed connections during their ICU stays, who had benefited from volunteer services, who continued needing human contact during their transition between life and whatever came after. They maintained partial existence in the ICU to receive ongoing volunteer support. I adapted my rounds routine to serve both living and phantom patients equally. I would visit officially occupied rooms first, providing standard volunteer services to current patients. Then I would visit the empty rooms where phantom patients continued their existence, offering companionship to individuals who existed between medical realities. The phantom patients' needs were identical to those of living patients: comfort, conversation, assurance about family concerns, help processing medical anxiety. They didn't realize they were dead or discharged. They experienced their ICU stay as ongoing, requiring continued volunteer support during extended hospitalizations that existed outside normal medical timelines. My documentation became an exercise in selective reality reporting. Official volunteer logs recorded visits to occupied rooms, conversations with current patients, services provided to individuals whose medical status could be verified. Unofficial personal notes documented phantom patient encounters, tracking ongoing relationships with individuals who continued needing volunteer support despite their changed existence status. The most profound phantom encounter involved Mr. David Williams, room 15, who had been requesting volunteer visits to help him write letters to his estranged daughter. Over several weeks, we worked together composing messages that expressed his regret about their relationship, his hope for reconciliation, his desire to make amends before his death. According to hospital records, Mr. Williams had died 3 weeks before our first letter-writing session, but he continued meeting with me, continuing our work on family reconciliation, treating our volunteer relationship as ongoing despite his official death. The letters we wrote together felt real, meaningful, necessary for his emotional healing. During our final session, Mr. Williams completed a letter that expressed everything he'd wanted to say to his daughter. He thanked me for helping him find the words, for providing the volunteer support that allowed him to address unfinished family business. As he handed me the completed letter, he faded gradually, becoming translucent, then disappearing entirely. The letter remained solid in my hands, physical evidence of volunteer work that had occurred with a patient who no longer existed. I mailed it to his daughter, including a note explaining that her father had worked very hard to communicate his love and regret during his final days. She later called the hospital, grateful for the unexpected contact, moved by her father's words, comforted by knowing he had been thinking about their relationship. I understood then that volunteer work extends beyond providing comfort to living patients. Sometimes we serve individuals who continue needing human connection during their transition between life and death, who require volunteer companionship to complete emotional work that medical treatment cannot address. My role as an ICU volunteer had evolved to include phantom patient services, providing comfort to individuals who existed between medical realities, facilitating emotional healing that continued beyond official death or discharge, serving as a bridge between present volunteer programs and ongoing spiritual needs. The phantom rounds continue each night, serving patients who exist across multiple states of being, ensuring that volunteer companionship remains available to everyone who needs human connection during vulnerable times. Some patients require volunteer services that extend beyond their physical presence in the ICU, continuing relationships that began during medical crises but address spiritual concerns that outlast medical intervention. I still work the overnight volunteer shift, still provide comfort to patients who face frightening procedures and uncertain outcomes, But now I also serve phantom patients who continue needing volunteer support during their journey between life and whatever follows, understanding that some healing relationships transcend the conventional boundaries of medical care. My volunteer service has taught me that the ICU serves not just as a medical unit, but as a transition space where healing occurs across multiple dimensions of existence. Living patients receive medical treatment while phantom patients receive continued companionship. Both populations requiring volunteer services that acknowledge their ongoing need for human connection during profound transitions. The census may show empty rooms, but volunteer rounds reveal the ongoing presence of individuals who still need comfort, conversation, and the assurance that someone cares about their welfare during the vulnerable hours when healing, or transition, occurs in spaces that exist between heartbeats, between breath, between the certainty of medical documentation and the mystery of what continues beyond. The wall clock above the ICU nurses' station stopped at 3:13 a.m. every night for exactly 17 minutes, during which time none of the patients aged, none of the monitors updated, and none of the medications I administered appeared in the electronic records. My name is Jake Thompson, and I've worked as an ICU nurse at County General Hospital for 4 years. Night shift nursing requires constant awareness of time, medication schedules, assessment intervals, documentation deadlines, all governed by the relentless forward progression of minutes and hours. The wall clock serves as our central reference point, coordinating care activities across multiple critically ill patients who depend on precisely timed interventions. The clock malfunction began during my second week working alone on the night shift. At exactly 3:13 a.m., the red second hand would freeze mid-sweep. The digital display would hold its numbers static, and the soft ticking that normally provided background rhythm to our work would fall silent. For 17 minutes, time would simply stop. Initially, I assumed it was a minor electrical problem. Clocks in hospitals malfunction regularly due to power fluctuations, electromagnetic interference from medical equipment, or simple mechanical wear. I reported the issue to maintenance, who replaced the clock with a new digital model that should have been immune to the mechanical failures that affect traditional timepieces. But the new clock stopped at 3:13 a.m. as well, and every clock I could see from the nurse's station, the monitors, the medication pumps, the computer timestamps, all froze simultaneously, creating a 17-minute window where time ceased to function normally within the ICU environment. During those frozen moments, the ward existed in suspended animation. Patient monitors showed static readings that never fluctuated. IV pumps maintained their current infusion rates without updating total volumes administered. Electronic medical records froze at their current screens, unable to accept new documentation or display updated information. But the patients continued breathing, their hearts continued beating, and I continued providing nursing care within the temporal bubble that surrounded the ICU during those 17 minutes. The work felt normal, assessing patients, adjusting medications, responding to needs, but none of it registered in the time-dependent systems that normally tracked every aspect of patient care. I began documenting these temporal anomalies in a private journal, noting what occurred during the frozen time periods. Patients who had been agitated would become calm. Those who had been in pain would find relief. Individuals fighting infection would show subtle signs of improvement. The 17 minutes of stop time appeared to provide healing benefits that normal medical care couldn't achieve. Mrs. Eleanor Patterson, admitted with severe pneumonia, made her most significant recovery progress during the frozen time periods. While the clocks showed 3:13 a.m., her oxygen saturation would improve, her respiratory distress would ease, her fever would break. But when time resumed at 3:30 a.m., her condition would revert to its previous state, as if the healing that occurred during stop time existed outside normal medical progression. I started staying at bedsides during the 3:13 a.m. time freeze, observing what happened to patients when temporal constraints were removed. Without the pressure of continuous time progression, their bodies seemed able to focus entirely on healing processes. Wounds would close slightly, inflammation would reduce, pain would diminish. All temporary improvements that reversed when normal time resumed. The frozen time periods became opportunities for nursing care that transcended conventional medical limitations. I could provide comfort measures that seemed to last longer than 17 minutes, offer presence that patients remembered beyond the temporal suspension, deliver medications that appeared to work more effectively when administered outside normal time flow. During one particularly difficult night, Mr. Robert Hayes was dying from complications of heart surgery. His family had been called, last rites had been administered, and we were providing comfort care during his final hours. At 3:13 a.m., as the clock stopped, I sat with him holding his hand, offering presence during what appeared to be his final moments. But during the frozen time, Mr. Hayes opened his eyes and spoke clearly. "Jake, I'm not ready to go yet. Can you help me stay a little longer?" For 17 minutes outside normal time, we talked about his grandchildren, his hopes for recovery, his fear of leaving his family unprepared for his death. When the clocks resumed at 3:30 a.m., he had slipped back into unconsciousness. But his vital signs had stabilized, his condition had improved, and he survived another 3 weeks. Time that allowed his family to process their grief and prepare for his eventual death. I realized that the stopped time periods weren't malfunctions. They were gifts. The ICU existed in a temporal anomaly that provided additional healing time, moments outside the relentless progression of medical crisis where patients could focus entirely on recovery without the pressure of continuous deterioration. The 17-minute suspensions followed patterns that suggested purposeful intervention rather than random, mechanical failure. They occurred during critical moments when patients needed additional time to heal, when families required extra minutes to say goodbye, when medical interventions needed to work without the constraints of normal temporal progression. I began preparing for the nightly time suspension, positioning myself strategically to provide optimal patient care during the frozen moments. I would gather comfort measures, prepare important medications, identify patients who seemed most likely to benefit from temporal healing opportunities. During the stopped time, I could communicate with patients who were normally unconscious, provide pain relief that lasted beyond the 17-minute window, offer emotional support that patients retained even after time resumed. The temporal suspension created space for nursing care that addressed spiritual and emotional needs alongside medical requirements. My documentation became an exercise in describing care that occurred outside measurable time. Official nursing notes recorded standard medical interventions that appeared in time-stamped electronic records. Private observations tracked healing that occurred during temporal suspension, improvements that couldn't be explained by conventional medical progression. The most profound stop-time encounter involved Mrs. Catherine Foster, who had been brain dead for 2 days while her family struggled with decisions about life support discontinuation. During the 3:13 a.m. suspension, she became fully conscious, discussing her wishes for organ donation, expressing love for family members, providing closure that helped her loved ones accept her death. When time resumed, she returned to brain death, but her family had received the communication they needed to honor her wishes and find peace with their loss. The 17 minutes of stopped time had allowed a conversation that was medically impossible but emotionally essential for healing that extended beyond the patient to include grieving relatives. I understood then that ICU nursing involves more than managing medical interventions within normal time constraints. Sometimes we serve as guardians of temporal spaces where healing occurs outside conventional medical reality, where patients receive care that addresses needs beyond what standard protocols can provide. The stopped clock became my signal that deeper healing was possible, that the boundaries between life and death were more permeable than medical training suggested, that nursing care could extend into temporal dimensions where different rules governed recovery and transition. My final journal entry reads, "Time stops each night at 3:13 a.m. to create space for healing that transcends medical limitations. ICU nurse Jake Thompson serving patients across temporal boundaries. Some care occurs outside measurable time, in moments stolen from mortality's relentless progression. The clock still stops at 3:13 a.m., still provides 17 minutes of suspended time where healing occurs outside normal medical constraints. I still use those moments to provide nursing care that addresses spiritual and emotional needs alongside medical requirements, understanding that some patients require interventions that exist beyond the boundaries of conventional health care. The temporal suspension continues each night, creating opportunities for healing that hospital policies can't quantify, for conversations that medical records can't document, for care that occurs in the spaces between seconds where hope and love exist outside the relentless progression of time. I remain the night nurse who understands that some healing requires temporal suspension, that the most important nursing care sometimes occurs when clocks stop and eternity briefly intersects with the ICU, allowing patients to receive what they need most during the vulnerable moments between heartbeats, between breath, between the certainty of medical time and the mystery of healing that exists beyond measurement.